I'd like to welcome our speaker today. It's Anne Blades. Anne is a Senior Risk Management Consultant here at MICA. She received her Bachelor's of Science in Nursing from Viterbo University in La Crosse, Wisconsin, and holds a Master's degree in Business with an emphasis in Healthcare Management. Anne's practice experience includes medical, surgical, and post-anesthesia care. Anne has 27 years of experience in healthcare risk management, including 11 years of clinical risk management with a health system in Arizona, where she served on numerous committees and was involved in insurance and claims management. Anne has served as a past officer and board member for the Arizona Society of Healthcare Risk Management, as well as for the Arizona Association of Legal Nurse Consultants. She has over 15 years of large physician group risk management experience in Arizona as the Chief Risk Officer, and provided the development of the Risk Management Department, including claims, insurance, and education. Anne is the past president and CEO of a captive insurance company in Arizona. Over to you, Anne.
Thank you, Jeremy, and thanks for joining us today for a discussion on strategies for preventing maternal death and injury with a focus on the postpartum outpatient stage. So we have some CDC statistics that you might already be aware of related to maternal health patient safety concerns, and those are that greater than 700 women die each year from childbirth-related complications in the United States. More than 50% of those deaths are preventable, and then they have another 50,000 women who are felt to experience serious birth-related complications. The U.S. has the highest maternal death rate among the world's developed nations, and unfortunately, the U.S. maternal death rate is rising, and in most of the rest of the world, the maternal death rate is falling. There are some significant racial and ethnic disparity for maternal morbidity and mortality. Black and American Indian, Alaskan Natives are 3 times more likely to die from pregnancy complications than white American women. This disparity is more exaggerated with decreased access to healthcare due to fear or physical accessibility, and we're also seeing this disparity even greater with COVID-19. According to ECRI, maternal health across the continuum was their #2 patient safety concern for 2020. Many maternal deaths are preventable, and they also believe that there are many more complications in hospitals and after discharge that go unreported. Number 1 on ECRI's list is missed and delayed diagnosis, and ECRI indicates that there is now starting to be more data collection, but the true numbers are not known, so underreporting is considered to be a factor in this issue as well. Approximately 1/3 of deaths happen at delivery or in the week following delivery, and 2/3 of the deaths happen after delivery, leaving 1/3 of the deaths that happen from 1 week up to 1 year postpartum. There's always been a lot of focus on pregnancy and delivery in the immediate postpartum time. That's really an exciting time for a mom and a new baby. They're focusing on breastfeeding. Mom's focusing on caring for the baby, and she has a lot of changes that her body's going through. So now there's even starting to be some focus on the outpatient postpartum period to address some of the complications that people are noticing occurring in greater numbers. There are a lot of serious complications that can occur postpartum, even after hospital discharge. Many nurses in the hospitals are not aware of some of these complications, or really their focus is not on that because they're inpatient nurses. So it's thought that there might be some additional focus that could help on that issue as well. The CDC lists complications postpartum, sometimes referred to as the 4th trimester, as things such as cardiovascular conditions. That might include cardiomyopathy, which occurs sometime after discharge. A hemorrhage can occur days or weeks after leaving the hospital, maybe due to a retained piece of placenta, or there could be an infection from multiple sources, including a UTI, an incisional infection, a uterine infection that might lead to sepsis. Preeclampsia or eclampsia can happen even after delivery, and that can occur even in moms without hypertension during pregnancy or delivery. And then, of course, there's always the concern for mental health conditions. Postpartum depression is a known mental health issue, diagnosis, or substance abuse leading to overdose or suicide or some other concerns. So how do we get from getting the mom discharged till she looks okay till all of a sudden she ends up back in the emergency department? The mom might call their family physician and report symptoms and then be diagnosed with something else. The symptoms might worsen and she might end up in the hospital and ED with a misdiagnosis. So the question is, did the PCP that they called even know that the mom had recently delivered? Was the staff taking the call from the mom aware? And did the mom even think to report that she had recently delivered? Or if she was further out, did she even consider, oh, I probably still should tell my doctor that? One example of that could be cardiomyopathy, where the mom feels tired and not feeling well. She might even have a little shortness of breath, and she calls her PCP, but they just think it's normal maternal fatigue after delivery of a newborn. So what happens when the mom is discharged after delivery? There's typically a drop-off in the support and the attention the mom receives after delivery. There's new and more stresses of having a baby at home, and the mom might be physically exhausted from the care of the baby, having visitors, etc. And that can really all be very overwhelming. Some red flags to look for in recently discharged moms are fever, shaking, chills and body aches, shortness of breath, some discomfort or chest pain or abdominal pain. If the mom has weakness, she might feel faint, have a rapid pulse, and even you want to look for heavy bleeding. And heavy bleeding is typically described as soaking a typical pad greater than 1 per hour or having a sudden heavy gush of bleeding. In the outpatient setting, we probably need to ask some questions like, are the mom's symptoms getting worse? Are your symptoms getting rapidly worse? Are your symptoms not going away? Or do you have a feeling that something just isn't right? If people are saying something's just not right, I've never felt like this before, we need to really pay attention to what they're saying, especially if it's a husband or a support person or the patient themselves. Those are always concerning statements. So what should healthcare providers be listening for when they're taking calls from the mom in the outpatient settings? Sometimes the mom might not tell you that she delivered recently, especially if she's a little further out past delivery. Does the staff taking the calls know the red flags that we talked about on the previous slide? Does the office have screening questions, like have you checked your temperature? Other symptoms might be chills and body aches, bleeding. And if it's bleeding, you really want to quantify the bleeding in terms of amount, color, and does the bleeding have clots? And eventually, you want to escalate the care of the patient. If it's appropriate, they might need an urgent appointment in the office or even go to urgent care or the emergency department if appropriate. Mental health concerns are something we want to discuss because the mom may or may not be comfortable or even recognize if she has postpartum depression. So you want to be on the lookout for new or escalating depression. Using screening tools is a way that you can do that. And sometimes their spouse or partner or coach will be the one person to raise that issue as well because they know them the best and notice a change in them. There's some additional things that we should consider as we work through COVID-19, and those include that women may not be seeking care, or they might be skipping their postpartum visits because of fear of contracting the virus. Some might even seek a home delivery versus a hospital delivery, and that's most concerning if it's a last minute decision to do that and there's not able to be a good transition of care for the mom to another provider. Postpartum women are also at increased risk for contracting an infection because there's lots of stressors on the body. And hospitals do have some rules that not having supportive partners during childbirth. Most, however, allow at least one person in the delivery room to support them. And then, of course, there's the isolation with COVID-19 precautions. After delivery, the mom might be isolated at home and be by themselves with the new baby. They might be tired, have a drop-off in visitors, and all those emotional and physical challenges might add up to be a little bit more than they can manage. So those are considerations in terms of COVID. So what can we do to get all the players on the same page? Well, first of all, we want to have awareness and education for healthcare workers and patients on the postpartum delivery complications. There's always been a lot of focus on pre-delivery and actual delivery, but we probably want to add some more focus on the postpartum delivery complications. We want to start patient education during pregnancy and incorporate warning signs and postpartum complications. We want to include the support person and partner in the education because, as we said, those people are often notice things that the mom may not herself recognize. Implement and update triage protocols for postpartum patients and train the office staff on questions to ask postpartum women. Some additional strategies are to identify the partner and coach, again, valuable source of information, And then include the EDs on the education, both the physician and the ED staff. Expand simulations and trainings to outpatient settings, maybe on postpartum hemorrhage or sepsis recognition. And keep in mind mental and physical complications, as well as expanding data collection on post-delivery complications. With more information, we can maybe determine where the trends are and where to focus our efforts. But overall, we just want to reinforce that these complications are not just in the immediate post-delivery phase in the hospital. They can occur up to 1 year post-delivery. This last slide is just a list of resources that are well known to many of you, so I won't go through them. And with that, I want to thank you for joining us on this presentation on strategies for preventing maternal death and injury.